Welcome, everyone, and thank you so much for attending our webinar, which is highlighting the most recent update to the ACCP guidelines on antithrombotic treatment of VTE disease. And of course, this webinar is hosted by the Anticoagulation Forum, and we thank everybody for their participation. Before getting started, and as people are logging in, we wanted to acknowledge that today is Veterans Day in the United States and Remembrance Day in Canada, where I live. So we wanted to take a moment to acknowledge the importance and dedication and sacrifice of service people and veterans in both of our countries today. We are fortunate to be joined today. I'm Deborah Siegal. I should introduce myself. I'm an associate professor at the University of Ottawa. And I'm very fortunate to be joined today by my colleague and mentor, who is an internationally renowned thrombosis expert and researcher, Phil Wells, who is also from the University of Ottawa and was an author on the guidelines that we are going to discuss today. We also have stellar moderators in attendance, Jeff Barnes, who's a cardiologist and vascular medicine specialist at the University of Michigan, and Andrea Van Beek, an anticoagulation clinic nurse practitioner in California. So welcome, everyone. This slide shows our disclosures and notification of support, and I'll leave it up for a moment for you to review. So these are the guidelines that we're going to be discussed today. They were recently published. This is the Antithrombotic Therapy for VTE Disease second update of the CHEST guideline and expert panel report. And before we get into the nitty-gritty of the guidelines themselves, I wanted to provide a bit of an overview about the guidelines and the guideline process here, and so we could place the recommendations into some context. So as a background, this was a second update to the 9th edition of these guidelines, and there were recommendations on 17 PICO questions. Those are clinically related questions, and we'll talk a bit about those and what they are in a couple of slides. They used grade methodology for this guideline, which included both strong and weak recommendations, and the strength of recommendations were based on the certainty of evidence. All in all, there were 29 guidance statements with 4 new statements in the previous version in 2016 and 8 modified statements. And of course, this is a lot of information packed into one document, so we're going to focus on a few areas of controversy, and we'll get to that in a few slides. So the questions that form the basis for recommendations in this guideline were defined using the PICO framework. So that's what I mentioned earlier. PICO stands for Population, Intervention, Comparator, and Outcomes. And you'll see in some upcoming slides how those are incorporated into the guidelines and how they essentially guide the recommendations that were made. This guideline was structured according to the chronological events that occur in the management of VTE. So they start out with whether to treat, then continue with interventional and adjunctive treatments. There's the initiation phase, which is sort of 5 to 21 days of treatment, the early phase. Then there's the treatment phase, which is the first 3 months of treatment. And then finally, the extended phase, which is 3 months to no planned stop date. So again, this is the chronological order in which patients with VTE are assessed and managed. So how did they arrive at these recommendations? So you're going from evidence from individual studies and pooled using meta-analytic techniques. And then finally, a recommendation is made. In this case, it's the decision. And this evidence to decision framing is based on the certainty of evidence. So what does that mean? So that is our confidence that the effect estimate, and here we're talking about the estimate of treatment effect, for example. So our confidence that the effect estimate, is adequate to support a recommendation. So you'll see high, moderate, low, or very low certainty of evidence. And this ultimately reflects the strengths and limitations of the underlying body of evidence, and that it could include things like study design, risk of bias, imprecision, which means that there's wide confidence intervals, or we're not sure about where that effect estimate lies, inconsistency between studies, the indirectness of the evidence, relating to the specific patient population that we're discussing, or publication bias. And so only certain types of studies were published, perhaps positive results only. And then secondarily, so we have the certainty of evidence, and this obviously informs our confidence in the estimate and reflects the strengths and limitations of the evidence. And then we have the strength of a recommendation, which is the extent to which we can be confident that the desirable effects of an intervention or the benefits outweigh its undesirable effects or the harms. And this is categorized as strong or weak. So you'll see a combination of these two, strong or weak recommendation based on a certain level of certainty of evidence. So how should patients and clinicians really use these recommendations? So when we talk about a strong recommendation, you'll see the wording in the guideline, which says we recommend. And what does that mean for patients? Well, that most individuals would want the intervention. And then for clinicians, it means that most individuals should receive the intervention. And when the panel made a weak recommendation, you'll see the wording there is we suggest. This means for patients that a majority would want the intervention, but many would not. And for clinicians, that different choices would be appropriate for different patients depending on their values and preferences, and that shared decision-making should be used. In fact, shared decision-making should always be used. So with that sort of brief introduction to the guideline itself, we're going to focus on 4 areas of uncertainty in clinical practice. And of course, you're very welcome to ask questions about other aspects of VTE treatment that are covered in these guidelines or in general. And I also wanted to use this as an opportunity to remind people that please share your questions in the chat box that you'll see, and we'll be able to have some time for discussion afterwards with our panel. So the 4 areas of uncertainty that I wanted to discuss today were the isolated distal deep vein thrombosis, or DVT, isolated subsegmental pulmonary embolism, or PE, cerebral vein thrombosis, and extended phase therapy, or ongoing anticoagulation. Sometimes we refer to this as duration of anticoagulation. All of these are uncertain areas, and folks often have questions about management. So we'll start with a case for the first section. This is a 52-year-old man with no past medical history and no major VTE risk factors. He's hemodynamically stable and has an elevated BMI of 32. His laboratory investigations are normal. He's presented with a 1-week history of left calf pain and is found to have an acute thrombosis of the left posterior tibial vein on compression ultrasound. So the corresponding PICO question here addressed by these guidelines is, should anticoagulant therapy versus no anticoagulant therapy be given to patients with isolated distal DVT? This is a posterior tibial vein. It's a vein that is below the leg, or considered a calf or distal deep vein thrombosis, as you can see in the diagram on the right-hand side. So I'll walk you through this table. This is a selected summary of findings table, which was included in the guideline. This is what we call the evidence profile. And you can see on the left column, the outcomes here, the outcomes of interest, recurrent VTE at 3 months, major bleeding at 3 months, and overall mortality at 3 months. And on the right-hand side, you see the absolute effect. And remember, we're talking about treatment versus no treatment here. So we see the absolute effect of treatment compared to no treatment was 60 fewer events per 1,000 cases. So reduced recurrent VTE at 3 months, 2 fewer events per 1,000 cases for major bleeding, and 0 fewer events per 1,000 cases for mortality. You also see there the confidence intervals, and that actually can be really helpful. So let's take the recurrent VTE at 3 months outcome, 60 fewer events per 1,000 cases, but that our confidence intervals take us to from 77, so it could be as low as 77 fewer or as high as 21 fewer. And that's a way for us to understand the confidence intervals here when thinking about the absolute effect of treatment. So again, should anticoagulant therapy versus no anticoagulant therapy be given to these patients with isolated distal DVT? And so this is how they framed the answer. In patients with isolated distal DVT of the leg, they separated these recommendations into 2, patients without severe symptoms or risk factors for extension, or those with severe symptoms or risk factors for extension. So in patients who have distal DVT without severe symptoms or risk factors for extension, they suggest serial imaging of the deep veins for 2 weeks over anticoagulation. And this is a weak recommendation based on moderate certainty evidence. On the other hand, if you have a patient with severe symptoms or risk factors for extension, then they're suggesting anticoagulation over serial imaging of the deep veins. And again, this is a weak recommendation based on low certainty evidence. And here what they're talking about when we talk about serial imaging, it's repeating an ultrasound once weekly or with worsening symptoms for 2 weeks, and then deciding on anticoagulation only if the distal thrombi propagate. They're also recommending here that if anticoagulation is given, that the same regimen be used as for acute proximal DVT. So what happens if a patient actually does have if a patient has a distal DVT in the leg and they're managed with serial imaging, and you do your serial imaging, and then what? So the guideline panel is recommending no anticoagulation if the thrombus does not extend. So you do your serial imaging, and at the end of 2 weeks, there's no extension, no anticoagulation. This is a strong recommendation. However, if the thrombus extends but remains confined to the distal veins, then they're suggesting anticoagulation here. Again, this is a weak recommendation based on very low certainty of evidence. Again, the body of literature here is quite limited. And then finally, if the thrombus extends into the proximal veins, here now we're recommending anticoagulation with a strong recommendation and moderate certainty evidence. And again, if we look at other guidelines, you can see here on the right-hand side, in the ASH guidelines, there was no specific guidance on this. And same with the NICE guidelines, recommendations really only for proximal veins. And it's important that there are some additional considerations here that the panelists include in the guideline itself. So there are some considerations on the left-hand side of the screen you can see which favor choosing anticoagulation. And these may or may not include a positive D-dimer, extensive thrombosis, a thrombosis that's very close to the proximal veins. The patient has no reversible provoking factors, active cancer, a prior history of VTE. The patient is hospitalized, has a COVID-19 diagnosis, or is highly symptomatic, or they prefer to avoid repeat imaging. And in fact, in clinical practice, we do take a lot of these considerations into account when we're making these decisions. And then finally, on the right-hand side, you can see some factors which favor choosing serial imaging over anticoagulation, and that might be thrombosis of the muscular veins like the soleus or gastrocnemius veins, if the patient is at a moderate or high risk for bleeding, or if they prefer to avoid anticoagulation. These are some additional considerations. So again, we have recommendations and we've graded them as strong or weak. Mostly these are weak recommendations based on low certainty of evidence. And so it's important to take some of these additional considerations into account when making treatment decisions. So I'm going to switch gears now and focus on our second scenario or our second case. This is a 60-year-old woman who has dyslipidemia and hypothyroidism with no VTE risk factors known. And she's assessed in the emergency department for chest discomfort. She undergoes CT pulmonary angiogram and is found to have a single subsegmental pulmonary embolism in the right lower lobe. A bilateral compression ultrasound of the legs was done and is negative for deep vein thrombosis. So the PICO question that corresponds to this recommendation about subsegmental PE is, should anticoagulant therapy versus no anticoagulant therapy be given to patients with isolated subsegmental PE? And so again, the guideline itself addresses this question by separating the patients into two categories. One category is patients at low risk for recurrent VTE, and the other category is patients deemed to be at high risk for recurrent VTE. So in patients with subsegmental PE, and what we mean here is that there is no involvement of more proximal pulmonary arteries and no proximal deep vein thrombosis in the legs. For patients who are at low risk for recurrence, clinical surveillance is suggested over anticoagulation. And this is a weak recommendation based on low certainty of evidence. However, if patients are deemed to be at high risk for recurrent VTE, the panel suggests anticoagulation over clinical surveillance. And this is also a weak recommendation based on low certainty evidence. And in fact, this recommendation was unchanged from the prior update of these guidelines because there really aren't any additional high quality studies that address this question. However, there are some that are ongoing. And I just wanted to mention here that, the challenge we face, I'm sure you're quite familiar with this. The challenge we face is that there is uncertainty about whether isolated subsegmental pulmonary embolism is a true filling defect, like a true thrombosis, versus an artifactual finding that's based on poor opacification of of these distal small caliber vessels. And this obviously would have important prognostic implications because it means there's either a clot or there's not. And so that's why I think some of the recommendations you'll see or some of the considerations that are listed are really aimed at assessing whether or not this is a true thrombosis finding or an artifact. Sorry about that, just having some technical issues. Okay, so what do the panelists, what does the guideline tell us about understanding or taking some of these considerations into account? So on this side, you can see that isolated subsegmental pulmonary embolism is more likely to be a true positive if there is a high quality CT-PA with good opacification of the distal pulmonary arteries. And sometimes this will be reported in the report itself. If there's multiple intraluminal defects, so not just one, but multiple, if the defects involve more proximal segmental, so they're more proximal subsegmental findings, like they're a bit larger. If the defects are visualized on more than one image on the scan, if the defects are surrounded by contrast as opposed to just against the wall, and here, if the patients are symptomatic, so if there's a high clinical pretest probability of there being a clot, and if there's an elevated D-dimer. And in fact, probably the most important and most helpful thing to do is to liaise with the radiologist. And we do this routinely in our clinical practice. We really want to understand, are these true findings or is this an artifact? And this can be extremely helpful and in fact change the whole course of treatment for a patient. You're committing them to 3 months of or some form of anticoagulation or not. And it's actually quite important to do that. And also what you want to do is assess for risk factors for recurrence, progression, or adverse outcomes. And so these are things like hospitalized patients, those with reduced mobility, those with active cancer. If there's no reversible risk factor identified, sort of like unprovoked, if they have low cardiopulmonary reserve, that's not necessarily a risk factor for recurrence or progression, but it is potentially a risk factor for adverse outcomes. The patient has marked symptoms, if they're moderate or high bleeding risk, or if they prefer to avoid anticoagulation. And these are also, again, additional considerations. Now we have suggestions here for the recommendations. There are weak recommendations based on a low certainty of evidence. So again, these additional considerations are quite important to make when faced with this decision about treatment. I'm going to move on to the third case. And of course, again, we're going to have lots of time for questions and we can revisit some of these as is desired by the audience. This third case is switching gears a little bit. This is a 60-year-old woman who has a persistent and severe headache for 2 weeks. And it's unremitting, and she's been to the emergency department several times for this. And on the third visit to the emergency department, an astute emergency room physician orders a CT venogram, which shows a left frontal cortical vein thrombosis with a small amount of subarachnoid hemorrhage. She's otherwise healthy with no medical history. There's no family history of VTE, and she has no identifiable VTE risk factors. So the PICO question here that the guideline used to address this is, should anticoagulant therapy versus no anticoagulant therapy be given to patients with cerebral vein thrombosis? And I wanted to highlight cerebral vein thrombosis in this presentation because it is rare, but there is also a lot of uncertainty about management. And recently, when we've seen an increase in the risk of cerebral vein thrombosis with the adenovirus vector COVID vaccines, it sort of has come onto the radar of a lot of practitioners. And so although we're not specifically talking about COVID for this presentation and these guidelines, I just thought it would be important to mention and to say that, although there is a limited body of evidence about this particular type of venous thrombosis, there are ongoing studies to further understand the natural history and the treatment strategies that are best. So this is a summary of findings table. And again, based on really limited evidence, there are a couple of small randomized trials evaluating anticoagulation. What you see here on the left is the outcome of overall mortality at 90 days. And then the second outcome here is new intracranial hemorrhage or PE at 90 days. Again, a composite outcome. They're very different events. ICH and PE are quite different. So here, I think it's important to see these numbers, but again, there's a lot of uncertainty about the outcomes with respect to CVT. And in fact, these patients are not just at risk for recurrent CVT, they're at risk of recurrent VTE overall. So it's something important to keep in mind, especially when we're thinking about the duration of anticoagulation. So overall mortality with treatment, 108 fewer events per 1,000. So really important here. Anticoagulation appears to reduce overall mortality. And then with regards to new ICH or PE, 69 fewer events per 1,000 cases. That also, to me, is important to know. Intracranial hemorrhage in the setting, as in our case, can be a finding in patients with cerebral vein thrombosis. So what you have is you have a thrombus in the cortical vein in this example, or another type of cerebral vein, and it creates back pressure, and you get subarachnoid hemorrhage because of venous obstruction. And so often these can go hand in hand, and it's really important to identify that on the imaging. But you have to have a high index of suspicion for these types of clots and order the appropriate imaging, which in this case is usually a CT venogram, although MR venograms can also visualize these clots, but a routine CT without contrast and even a regular CT with contrast is insufficient for assessment of CVT in a patient with a high pretest probability of that condition. So again, we're returning to our question here, which is, should anticoagulant therapy versus no anticoagulant therapy be given to patients with cerebral vein thrombosis? And remember, I just told you that often subarachnoid hemorrhage or intracranial hemorrhage can accompany the cerebral vein thrombosis. And this is on the basis of venous obstruction and increased pressures. And so you can see here that in patients with cerebral vein thrombosis, the guideline is recommending anticoagulation therapy for at least the treatment phase. So that would be the first 3 months over no anticoagulant therapy. And this is here a strong recommendation based on low certainty evidence. Now, what's interesting about this recommendation is the panel upgraded this recommendation to a strong recommendation because they placed a very high value on an uncertain but potentially life-preserving benefit. And we saw that based on the summary of findings table, that if we go back here, 108 fewer events per 1,000 cases. So there were some comments that they included, which I think are maybe important to review at this point. Some of the comments were that dose-adjusted heparin or low molecular heparin can be used. And although there's not evidence to suggest that one is superior over another, and that wasn't evaluated in this particular guideline, low molecular heparin has many advantages over intravenous unfractionated heparin. Parenteral therapy is recommended until a patient is clinically stabilized. The treatment phase in cerebral vein thrombosis is actually much less well-defined than in DVT or PE. And in the studies that have been done, treatment can range from anywhere from 3 to 12 months. And then sometimes extended anticoagulation is considered, and when a CVT happens in the absence of hormonal or other provoking factors, or there are persistent risk factors for recurrent CVT. There's a long list of risk factors, and in fact, the majority of patients with cerebral vein thrombosis from the observational studies that have been done actually have a risk factor for CVT, and often those are hormonal in nature, like combined oral contraception or pregnancy, but there are others. And so I just thought it would be important to bring this to the forefront. There's much more uncertainty here than we see with some other types of VT, but that just means that there's opportunity for further study and to improve outcomes for these patients. And then finally, for the last case, now this one is something that we encounter a lot, and there's often a lot of discussion and shared decision-making with patients that occurs with this scenario. So in this scenario, I've provided 3 sub-scenarios. This is a 74-year-old man who has a bilateral pulmonary embolism after hip replacement surgery. This is something we see commonly in clinical practice. And in scenario 1 here, he's completed 3 months of anticoagulation too. Okay, so the first case is a patient who has a major transient provoking risk factor that is now gone. In scenario 2, is the same 74-year-old man has a bilateral PE after flight to New Zealand from the United States. And he's completed 3 months of anticoagulation again. So here is a VTE that's occurred in the context of a minor transient risk factor. And then finally, in scenario 3, we have a 74-year-old man who has a bilateral PE in the absence of any identifiable provoking factors, who has completed 3 months of therapy. And so the PICO question here that's addressed in the guidelines is, should extended phase anticoagulant therapy, and here they mean after 3 months, versus no extended phase anticoagulant therapy, be provided to patients with VTE who have completed that initial treatment phase of therapy? And so this is a busy slide to sort of incorporate all of these different scenarios. And you can see that we'll take them one at a time. For patients with major transient risk factors, like the patient that I suggested who had PE after a hip replacement surgery, the guideline is recommending against offering extended phase anticoagulation. So discontinuing anticoagulation after 3 months, and this is a strong recommendation based on moderate certainty evidence. However, if the patient had a minor transient risk factor, and this would be like the flight to New Zealand, for example, the panel is here suggesting against offering extended phase anticoagulation. And this is a weak recommendation based on moderate certainty evidence. You can see here that the type of risk factor and the type of scenario, in fact, actually influences the recommendation here, not the recommendation itself, but the strength of the recommendation. And that's actually something that's important, and perhaps people will want to discuss in the question and answer period. And then finally, in the absence of a transient provoking factor, we call this an unprovoked, or in the absence of a persistent risk factor, so no provoking factors, the guideline here is making a recommendation for offering extended phase anticoagulation with a DOAC. And in patients who are not eligible for a DOAC, that's in green here, they're suggest offering extended phase anticoagulation with a VKA. And so the recommendation for a DOAC is strong, the recommendation for a VKA is weak. So what is the basis of this? So again, this is a summary of the findings. And you can look at the important outcomes on the left-hand side here: recurrent VTE, major bleeding, and all-cause mortality. And you can see the absolute effect of extended versus time-limited anticoagulation. 64 fewer events per 1,000 cases. So 64 fewer recurrent VTE per 1,000. For major bleeding, 6 more major bleeding events per 1,000. And for all-cause mortality, 4 fewer events per 1,000. And that really forms the basis of the recommendations that we talked about on the previous slide. So let's say we still have this case. This is a 74-year-old man, and this is a man who had a bilateral PE, this time in the absence of provoking factors, so an unprovoked PE. And he's been treated with 3 months for anticoagulation with a DOAC. And based on these recommendations, he's offered extended phase therapy, and he agrees to therapy. So then the PICO question that's addressed by the guideline is, should reduced dose 10A inhibitor, apixaban or rivaroxaban, versus full dose 10A inhibitor, apixaban or rivaroxaban, be provided to patients who have been selected to receive extended phase anticoagulant therapy, just like our patient here? So these are the summary of findings. These are the meta-analysis, which was done for these outcomes. You see on the left, again, we have recurrent symptomatic VTE, major or clinically relevant non-major bleeding, and mortality. So with regards to symptomatic VTE, with reduced dose versus full dose factor 10A inhibitor, there's 2 more events per 1,000, major or clinically relevant non-major bleeding, 10 fewer events per 1,000 with reduced dose versus full dose. And mortality here is not estimable, so we can't really comment on that. So what did the guideline panel recommend? In patients who are offered extended phase anticoagulation, so our patient again has completed now 3 months of therapy for an unprovoked pulmonary embolism, the panel suggests the use of reduced dose apixaban or rivaroxaban over full dose apixaban or rivaroxaban, and this is a weak recommendation based on very low certainty of evidence. And I think it's just important to keep that in mind. This is a tricky scenario that we face every day in the thrombosis clinic. And all will, I'm sure, elicit lots of discussion from the audience and often amongst thrombosis providers. Some considerations here are that the drug and dose of drug is informed by lots of different variables, and the panel members do acknowledge this in the guidelines themselves, including BMI, renal function, adherence to the dosing regimen, and cost. And those are all important considerations here. So that's sort of a run through of 4 areas of uncertainty from the guidelines. And of course, with the hours that we have, not enough time to address all of them, but I hope this has been an opportunity for you to learn about the recommendations and some of the considerations made for scenarios with isolated distal DVT, isolated subsegmental PE, cerebral vein thrombosis, and extended phase therapy. And there's lots of time for questions. I hope that people will take up the opportunity to ask questions of our illustrious panel, and we'll be happy. Please again, enter your questions and answers into the chat box, and we'll be happy to address them. I'm going to forward my slides here as my panelists join me on the quote stage.
Wonderful. Thanks so much, Deb, for that excellent presentation. Phil, I wonder if you want to offer any comments or reflections before we jump into some of the discussion. We're getting a lot of questions through the Q&A, so I'd encourage you to click on that Q&A button if you want to submit a question.
I just comment that the guidelines are developed generally to address common scenarios, but there's always many different nuances to the patient that can't be addressed necessarily by a guideline. And that's why, as you saw in many of Deb's slides, there were lots of conditions that should be considered when it's not a strong recommendation. So it's a difficult process.
I also want to ask you, a question came in early, and I think it's a question many of us had. ACCP, or what we often refer to as the CHEST guidelines because of where they're published, we had this big compendium that came out back in 2012 that had updated some prior versions. But then after that, we only saw a single update in 2016, and many people thought that the ACCP group maybe was out of the VTE guidelines, that it perhaps had been passed off to ASH or other groups. And many were surprised perhaps to see this come out earlier this year. Can you offer us any insight into how these decisions are made to do these updates or these guidelines? And is this something we should continue to expect, or what can you share?
Well, to my knowledge, ACCP will continue at this point. There was some concerns after the 2012 guidelines because this is a very expensive undertaking. The meetings were taking place in person for several days. People were flown in. It was a lot of work, and there were concerns over budget. Now things have gone virtual, and a decision was made that we wouldn't do all the guidelines wholesale every 4 years as they were doing in the past. There really isn't enough to justify that. So the decision was to try and make it a more living evaluation, whereas evidence comes up, then we revisit it and republish it. But there was talk of that. So I imagine some people thought, well, we still want guidelines. So they went and started the ASH guidelines. There's also potentially those who more and more experts in our field, thankfully, but also they want to have a say. And everybody thinks they can do something better than the other guy. So that might have been some consideration as well. And lastly, I think also they're starting to have some concerns at the ACCP about conflict of interest. And there's a lot of debate about how many, should we have experts involved in the panel or just non-experts who evaluate the evidence? And a lot of people feel it is very important still to have experts, even when there's some potential conflict of interest. Because it's just by the nature of our jobs, the people who publish tend to be those who end up having conflicts of interest, but they are still also quite knowledgeable individuals, and it'd be a shame to lose that expertise. So I think all that sort of triggered a number of folks to create their own guideline groups.
Great. Gosh, thank you both. This is just an excellent presentation and excellent guidelines. And we've really been getting a lot of questions in the chat box. And I think the top question so far, and even prior to the presentation, is, can we use a DOAC in cerebral vein thrombosis? What's your take on this? Does the guideline address it at all?
Well, the guideline didn't address that because there wasn't any data at the time when we did the guideline. There's now been at least one trial where there's been a randomized comparison of dabigatran to low molecular heparin and warfarin with very good outcomes, basically no difference between the two. Small study, only I think 120 patients in total. But I know in our practice, that's what we're tending to do. There's no reason for them not to be effective in this scenario as far as we can see. And so we have started using them routinely after the first week once patients have been stabilized. And although I don't have formal data to support it, it seems like that is working well. And I know there are other studies and other registries that will come out demonstrating that DOACs are probably quite a reasonable choice in this disorder.
Great, great. Would you continue a patient if they required long-term anticoagulation for the cerebral vein thrombosis if we decided that there were factors that meant we should continue it? Would you continue the patient on standard dose, or would you reduce dose after a period of time? Or is there any information to suggest one way or another?
Well, that's directed to me. There isn't any evidence to tell us one way or another. I think there is a fairly good body of evidence to suggest that this disorder is more common in women than in men, and that women have a lower risk of recurrence than men. And so probably they need a shorter duration of therapy. And that's been my practice, to treat for 6 months, especially if it's been associated with oral contraception or hormone therapy. Most of them apparently seem to be associated with that in women. So those drugs are stopped. And then therapy is often stopped after 6 months. We had a small registry that looked at that and showed it was probably, that was adequate. And others have also demonstrated that. So that's my practice. But Jeff and Deborah, your thoughts on that?
Yeah, so that's, there are a few guidelines that are looking at CVT, and I'm involved in, there's a new Canadian version of the guidelines coming out. And what's clear is that there really just is a lack of data about, the optimal duration of treatment for these patients. It may be helpful to be able to identify major provoking factors. Often, like Phil said, they're, hormonal factors or during pregnancy, but other factors like obesity is really common. And you want to make sure that the person doesn't have malignancy. So I think it's important to understand the context of the patient. What exactly is, are there any other underlying persistent or transient risk factors at diagnosis? And then, of course, many patients will be treated for anywhere from 3 to 12 months. Depending on that, it'd also be good to liaise with neurology if patients are still having symptoms and have persistent thrombosis in the cerebral veins. You'd be more likely to continue for longer, but it's unclear whether or not additional treatment actually does help resolve those symptoms and any residual thrombosis that remain.
I want to take sort of a turn from this. Obviously, cerebral vein thrombosis and splanchnic vein thrombosis are uncommon locations for venous thrombosis, although common enough that guidelines and studies often address them. But yet we also see thromboses in other even less common places. And there have been a couple questions, what do you do when you get a thrombosis in a retinal vein? What do you do when you get it in an ovarian vein? And Phil, maybe I'll start with you. Obviously, these are so rare, the guidelines don't address them. Do you have any thoughts as to sort of how you approach treating or making treatment decisions for these really rare location clots? Do you try and follow in general what guidelines say? Do you have some other practice patterns that you use? What's your sort of mental model there?
Is that directed to me or Deb?
I'll start with you and see if you have any thoughts.
Well, I think a lot of these are, a lot of ovarian clots are detected by chance or post hysterectomy or ovarian surgeries. And if they're small and I think they're self-limited. So, as you know, the left ovarian vein drains into the renal vein and the right into the IVC. So if you did see extension, it's kind of like, I sort of treat them like a distal DVT. If it looks like it's knocking on the door, going into a more important vein, then I might tend to treat it for 3 months, no longer than that. But a lot of these resolve spontaneously with anti-inflammatories or a tincture of time. So like you said, not a lot of evidence to guide us. So again, it becomes an individualized thing. It can be normal. If you've had your ovary removed for surgery, it's probably normal to have a clot within your ovarian vein that probably is self-resorbing and self-resolving, just like splenic vein thrombosis after splenectomy. So I think a lot of them don't require treatment, in my opinion, but you do want to see if there's persistent symptoms or if they're knocking on the door that might push you towards treatment.
Yeah, and the other thing, and Deb, I'll maybe throw this to you. You mentioned in your presentation that sometimes it's important to really bring different experts together. And these, to me, feel like situations where, you know, a retinal vein thrombosis, let's talk with our ophthalmologist, an ovarian vein thrombosis, let's make sure that the GYN is involved in sort of having these conversations, because they're not just our routine clots. And I'm wondering how often you do reach out to other specialists as you're trying to make decisions, especially for these less common clots that we see.
Oh yeah, really important. Multidisciplinary care is actually, not only do you learn, but I think you make, you know, the most high quality decisions for your patients. You're fundamentally gathering information, you know, that you may not have access to otherwise. You know, one of the scenarios where we encounter ovarian vein thrombosis is like colon, you know, for example, cancer, you know, gynecological or colon cancers, and those may be patients who are at higher risk of progression and progression into the IVC or some sort of, you know, different outcome or more adverse outcome. So it is important to take those things into account. With regards to splanchnic vein thrombosis, you know, at the top of the list is like intra-abdominal surgery, intra-abdominal infection, like liver disease, you know, is sort of like number one, number two, number three. And then way down is more rare kinds of conditions, you know, in the absence of any of those. So I think whenever you're, you know, evaluating a patient with one of those, it's important to know what the background is and know what context that happened, in which that happened. I totally agree. We do that all the time.
Definitely, definitely. I know for myself, I'm constantly speaking with other professionals, not only because they know a lot more than I do, but because as an anticoagulation nurse practitioner, I kind of am taking my cues. They turn to me for advice, but I'm taking a lot of my cues from other professionals. So I think that's a great thing to think about. Just to change gears a little bit, we talked about duration of therapy, which is always the question. And so in the guidelines, as well as in your practice, who do you continue on a higher dose DOAC after that first 6 months of therapy? Or would you ever reduce someone to that, you know, 2.5 of Eliquis or 10 of Xarelto after 3 months? Like, who would you keep on a higher dose long-term if they needed that?
So, you know, if you look at the studies, the earlier studies that used vitamin K antagonist, many of them used that 3-month cut point, but from the DOACs, all the studies have basically used a 6-month cut point, except for Hokusai, which was, it wasn't an actual, in Hokusai, they had 3 months. So they evaluated the first 3 months, 3 months to 6 months, 6 months, 6 months to 12 months, but all the others with the Apixaban and Rivaroxaban started that process at the 6 month point, which is why that's become our kind of starting point where we make the evaluation. And also when we derived the HER2 rule, we did it at the 6 month point. But having said that, many people feel the 3 month point is the point where decisions could be made. So we don't have a lot of evidence to make that dose adjustment at the 3 month point, but I'm sure there are many people who are tempted to. I would say for now, probably safer just to resist and wait till the 6 month point. Dose reduction, again, is a challenging and individual based decision. More and more, I think I'm reducing doses at 6 months in most patients, but I think some factors you want to consider, if they've had more than one VTE, you may not reduce the dose. If the patient's obese, you may not reduce the dose. Antiphospholipid antibodies, you may not reduce the dose. Strong thrombophilias, it's kind of hit and miss, maybe you shouldn't, but again, not enough evidence. And then you weigh in as best you can the patient's bleeding risk or their lifestyle. So, you know, I've had young patients who are very active in sport. And so my tendency in them has been to decrease their dose, have them take it at nighttime if it's a single day dose, because it's mostly out of your system by the time you're doing your sports the next day. But it's you have to factor in all those issues, including, as I said, bleeding risk. That's how I look at it.
I totally agree. And I think, you know, it's interesting when we, you know, those studies like Einstein Choice, which evaluated, you know, the Rivaroxaban versus aspirin, or Amplify Extension, which was the low dose Apixaban or regular dose of Apixaban versus placebo, you know, those really weren't powered for looking at major bleeding. So, you know, although they did collect information about major bleeding events or clinically relevant non-major bleeding events, we didn't really see a lot of bleeding events in even the standard doses. And so that is reassuring, I think, to some degree, but I should say that with a caveat as a person who's interested in bleeding complications, that, the case fatality rates for major bleeding and VTE and AFib as well are really high. So, 8 to 10% of people have a fatal outcome after a major bleeding event. It's important to keep that in mind. We're doing a lot of work now, Phil is as well, about understanding, how to tease out those different risks. It's important to talk to your patients about that. And so it changes. And a person who is perhaps elderly and frail, the consequences of a major bleed are, very significant. And so that does also influence my practice. I would, if I'm going to continue a patient on anticoagulation and I perceive them to be at higher risk, I will definitely reduce the dose. I routinely reduce the dose for most people, except folks like Phil mentioned, high body weight, which we have, and again, recurrent VTE. So those same sorts of things where you're just a bit worried that their underlying baseline risk is a bit higher, and they wouldn't have been maybe included in those studies very well, or very well represented in those studies. Again, those were patients in those studies. Most of the patients, so all of those patients were patients for whom there was equipoise about what to do at that 6-month time point. And that included people with unprovoked events, but also those with provoked events. We don't know if that was mildly provoked, strongly provoked, ongoing provoking factor. So again, it's just something to keep in mind. I think you do have some room, obviously, as a clinician to, vary your practice based on some of those considerations and the patient's preferences for sure.
Deb, I want to pick up on that last point you made, because we've had a couple questions here from the audience. And Phil, I'll direct the question to you. They're wondering why the panel chose to have that weak recommendation against extended duration for the patients who have the weakly provoked clot. And I'm thinking, Deb, you had a great example, that person who had that long plane flight, right? We're not really sure quite how strong a risk factor a plane flight is. And given the fact that some of the trials of extended duration, DOACs included, some of these, possibly provoked cases, the fact that the bleeding risks are relatively low, how did the panel come to that weak recommendation against extended duration? And, as a clinician, do you ever say, I'm going to go ahead and give them longer durations, even if it was say a flight situation like Deb described?
I think what it came down to is it wasn't clear that that kind of information was collected adequately in the trials. So it's a bit of a knowledge gap as to how the patients were classified and whether information was collected that would. So on the balance, that's why the group decided not to make it a strong recommendation, because it wasn't clear the evidence was informing that decision. In practice, my personal preference is to actually tend to consider those people higher risk when they have minor transient risk factors. Basically, you have a flight that's so rare to clot. To me, that's the same as an unprovoked clot. So my personal recommendation is I do extend therapy generally in those patients, again, addressing bleeding risk and cost, patient preference, et cetera. But we had to go with what the evidence gave us. And that's why that recommendation came about.
Yeah, I totally agree. That's my approach as well. You think, if a flight was enough for you to have a clot, it means that there's something about you there's some underlying increased prothrombotic risk. And I think most people, if you explain that to them in that way, they get that. All it took is a flight, for you to have your clot, as opposed to you had to have a big hip surgery to have your clot, right? And that's sometimes how I'll explain that to people so that they can understand those risk factors. And it's really important. Often it brings up an interesting point, and probably you guys experience this as well, where there's a lot of misunderstanding about what risk factors for VTE actually are and which ones are the most potent. And flight is always something that comes up as being, if you survey people, the general public about clots and risk factors, they'll say, oh, flights. Patients with cancer will say, well, I went on a flight. You said, well, you're being treated for metastatic cancer, which is a very important risk factor for thrombosis. The flight is meh. So it is actually just important to explain that when you're counseling patients about these risks.
Definitely. I think I've had several patients in my own practice that have been on a 2 or 3 hour flight, and they're like, oh, that was my provoking factor. And I'm like, I'm not so sure. So just to touch a little bit more about duration of therapy. So 3 to 6 months is the usual timeline for a provoked event. How do you in your practice do you choose 3 versus 6 months? Like, what's the magic number? Like, when do I push someone out to 6 months, and when do I say 3 is enough?
Well, as I said, in our practice in Ottawa is tend to be 6 months for a number of those reasons that I mentioned, and there's been no real convincing evidence that there's a big difference between 3 months and 6 months in terms of your later outcomes. But there also isn't a lot of research that would determine that. So if the patient is doing well and low risk for bleeding, we push that decision point out to the 6 months. Whether that, I can't say that's the right way to do it. I'm just saying that's the way that we do it.
Yeah, agreed. And even, you know, I was in another institution before McMaster, and we practiced very similarly. Although, you know, some had advocated, and even the late Clive Kieran, who also participated in the ACCP guidelines, used to say 3 months or indefinitely. And so there are definitely people out there, and that's kind of the spirit of these guidelines a bit too. 3 months is that kind of treatment phase. And then after that, it's kind of, you know, extended duration, because I guess it doesn't necessarily buy you any additional benefit to continue therapy. Patients have a lower risk of VTE while they remain on therapy. And then once you stop therapy, the risk kind of starts to go up, and it's highest in that first year after stopping. So, but in practice, we do tend to continue for 6 months. In a person who is, you know, at risk of bleeding, I would stop after 3 months. If I was very concerned about bleeding, they're frail, they're in very elderly, you know, multimorbid, perhaps need for other thrombotic therapy, something like that, I might consider stopping at 3 months, and I've done that.
So I don't think anybody can say that if you treat for 3 months and then you make that decision at that point, or you treat for 6 months and make the decision at that point,
Yeah.
don't say either is the wrong thing to do.
Right.
And it seems like that's supported. You know, we talked before, these are the CHEST guidelines or the ACCP guidelines. The ASH guidelines sort of give that 3 to 6 month window. So there is clearly a little bit of wiggle room depending on which set of guidelines you're looking at. But when you take a step back, it seems like the 20,000 foot view here is pretty consistent. There's a short duration, and then there's that extended phase or secondary treatment phase, and that's really the decision point. I wonder if I can ask one more question in this space. There's a number of people asking about cancer and thrombophilias and sort of how that impacts decision making. And Phil, I'm wondering if you can shed any light. Did the guideline panel directly think about addressing, or maybe how do you think about this, that secondary or extended treatment phase, if you have a patient with known cancer, whether it's still active or remote, whether you've got somebody with a thrombophilia beyond just a factor V Leiden, how much is that influencing the drug and the intensity, sort of the low dose versus the standard dose that you might give someone?
So I think most of the literature suggests that the thrombophilia is not that relevant a factor. But having said that, there are really that data doesn't come from a lot of patients with the more potent thrombophilias of CS and antithrombin deficiency. So certainly my tendency is to go extend therapy in those patients, because generally that's been identified because there's a family history, because they don't routinely test it. So there's probably other factors at play in those individuals that make it not unreasonable to continue anticoagulation. With respect to cancer, our practice has always been to continue indefinitely, because we feel the risk continues, although it's very clear the risk is highest in the first month to 3 months. And there's a randomized trial now looking at reducing the dose at 6 months. I have to say that I've been reducing the dose at 6 months for a long time, because what I'm observing in the extended phase is more issues with bleeding than recurrence. But that's based again just on my own experience, and I definitely would not say that's necessarily what everybody should do. But I think there's clearly room for evaluating that reduced dose in that extended phase in cancer patients and in patients with thrombophilia. It'll be harder in the thrombophilia patients. There's just not enough of them. But we should have the answer, I think, in cancer patients in a couple of years.
All right. Well, I think that kind of wraps up all the time that we have. I definitely want to thank everyone for being here today, all of our panelists, as well as all of our attendees. Of course, we couldn't do this without you guys. You're the reason we do this. So I'll toss it on over to Liz, and thank you all.
Yes, let me just echo my thank you. Deb, you covered a ton of material in those slides and were so clear. So thank you for that phenomenal presentation. Phil, thank you for your work on these guidelines and for sharing your expertise with us. And Jeff and Andrea, thank you for your amazing moderating. We had so many questions, so thank you for managing those. This webinar is accredited for pharmacists, physicians, and nurses, and you can claim credit at this link, and it's also in the chat or on the AC Forum website. We have a ton of AC Forum resources on VTE in our Centers of Excellence, so I just wanted to bring your attention to that. Please visit excellence.acforum.org. Also in the Resource Center is a literature update that you might find really helpful. It's updated every twice a month, every other Monday, and you can search. It's a curated search of all the literature that would be relevant in this field. And again, all of these resources can be found in the AC Forum Centers of Excellence Resource Center. In case you missed it, we had our national conference about 2 weeks ago, and all of the presentations, including the live Q&As and President's panel, is available for viewing through January 15th. So if you're interested, you can still register and watch all of that great content. And our next webinar is on health disparities and patient care. Could I have prevented a stroke? So please join us on December 16th for this important discussion. And lastly, I'd just like to thank our sponsors that support this program. Thank you all and have a great day.